couple quick notes, everybody. Thank you for your patience and hanging around with us. Contrary to what it says on the screen, I am not Kimberly Chalya. I'm Eric Heisler with PHCA. I'm filling in for Kim today. A few quick updates before we get started. This webinar is being recorded and will be made available on the PHCA website at the conclusion of this session. This webinar has been approved for 1 continuing education credit for all PHCA members in attendance. For those who provided an AB number, credits will be uploaded shortly. We'll also share certificates with those in attendance. A quick note about future webinars. In the coming weeks, PHCA will be launching a new website, including a more robust member account center. For future webinars will require attendees to use Zoom in order to receive credits. Zoom will be used to track attendance and help register credits. If you are already using Zoom, you're all set and don't need to do anything. If you are not using Zoom, Zoom offers free accounts that you can register for. When signing up, please be sure to use a company email address, as your company email address will be the unique identifier in our account center to ensure that you're getting those credits. For any questions, feel free to reach out to Kim. Now back to our webinar. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the chat icon on your screen, and we'll make sure we answer as many of your questions as possible at the end of today's presentation. Today's presentation is brought to you by the team at Actuated Medical. Your presenters are Maureen Molleville, Paula Mulhall, and Roger Bagwell. And I'll now turn the webinar over to our presenters, Maureen and Paula.
Hi, everyone. I'm Paula. I'm a nurse, and I have worked with older adults for a long part of my nursing career. And Maureen is here also. You're muted, Maureen.
Great. So hi, my name is Maureen Mulville, and I'm president and CEO of Actuated Medical, and we're very excited to be here today. Thank you.
Thank you for the introduction, Eric, and thanks for the opportunity, and thanks to all of you for taking time out of your busy lives to attend this webinar, and thank you again for your patience with the technical issues at the beginning. So we are going to just move along here. Our goal today is to discuss delirium and dementia and the differences between them and how they impact older adults' care. So the objectives, I'm just going to skim over these just for the sake of time. We will be discussing the differences between delirium and dementia. We're going to talk about the when we have delirium superimposed on dementia, the causes of it, the treatment, and then we're going to talk some about person-directed care for older adults, and we're going to talk about the My Medical Mirror, a companion case for older adults. So I know I'm preaching to the choir, so I'm not going to spend hardly any time on dementia because this is the world in long-term care. This is the world you all live in. So dementia is a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. So the take-home message with dementia is that it's an irreversible, progressive chronic brain disease. Important here, it's a slowly progressive and it's a disease. So it destroys memory and thinking. Initially, short-term memory is lost, and then later there's global deficits in all areas of function. We just need to all think about there's normal age-related changes like harder to retrieve information, cannot remember a name of a person as easily. Our ability to multitask gets changed a little bit as we age, but aging does not affect the core abilities of everyday life. We will remember how to turn on the dishwasher, how to turn on the washing machine, things like that. So delirium, on the other hand, this is an acute sudden condition, and it's characterized by a sudden and fluctuating decline in attention, awareness, and physical function. So the most important thing is a lot of family members, when they are dealing with delirium, either at home or even if they are visiting family members in long-term care or the hospital, the there's a lot of misinformation. They think that this sudden change in the condition is actually worsening of dementia. It doesn't work like that. So when it's a sudden change and when people cannot keep their attention focused, it is likely delirium. The good news on delirium is that it's reversible once the underlying cause is identified. It is very frightening because it causes confusion and at times combativeness. A lot of people know about delirium, and the term sundowners is used because it fluctuates during the day. And the minute there is some light reduction outside, 3:30 onwards, the symptoms of delirium become a lot more pronounced. I know all of you are very aware that there can be a family member visiting in the morning, and their family member, whoever is sick, is doing very well, reported to a sibling. The sibling comes in the evening and the person is completely different. That's delirium, exactly how delirium presents. Individuals with dementia have the highest risk of getting delirium. And with delirium, just to note, it's has only recently been separated from the treatment of dementia. It was always presented together, and the inaugural meeting of the American Delirium Society happened in 2011. And delirium is often diagnosed as encephalitis, encephalopathy, acute brain failure, organ failure of the brain, terms like that. So it's important to be able to tease that out when we talk about treatment later, which we will. And now we're just we have a side-by-side slide here. So with delirium, just to recap, it's an acute sudden condition that results in confusion, disorganized thinking, and agitation. People are often very combative, and its features fluctuate during the day and often referred to as sundowners. On the other hand, dementia, chronic disease versus a condition generally associated with old age, memory and cognitive function slowly degrade over time. Dementia has no cure, though there are some treatments currently that slow down the progress of the disease for periods of time. And it is a very hopeful time in the field of dementia treatment. I'm not going to talk at all about medications, but there's a few studies that are really bright on the horizon. One is the L-serine amino acid, which is found naturally in turkey, pork, edamame, sweet potatoes, eggs, tofu, and Americans get around 3 grams a day. So in the blue zones in the world, they get up to 30 grams a day, and they have increased longevity, much, much healthier conditions or life than Americans. So there's also a study with Dean Ornish, which has been in the news a lot in the last few months, about lifestyle changes, walking, plant-based diet, and meditation can reverse and slow down the progress of dementia after 5 years with that kind of a lifestyle. And then one of the studies that I'm keeping a really big eye on is the Houston Methodist current trial on the L-serine for the treatment of mild cognitive impairment. So mild cognitive impairment is the step before mild dementia. So they've already, they have a huge number of people in this study. They all have mild cognitive impairment. They are giving them this L-serine. They're giving it in pill form. They're giving 30 grams a day. They already have proven that 30 grams a day is a non-issue, no health risks or anything. And the results will be out next year to prove how effective it is on slowing down or reversing mild cognitive impairment. And then I'm sure most of you know about the finger study that was started in Finland and is now in 60 different countries. So again, another very hopeful treatment for dementia. So delirium, as we mentioned earlier, is the result of some underlying condition. It's temporary and relieved when the underlying cause is treated. It can be as simple as a UTI, which I'm sure many of you have seen, the confusion that can come with that. Dehydration is a very fixable form, a cause of delirium. It happens quite often, especially in the warmer months of the year. Pain can cause delirium, infection, very high risk with anesthesia in older adults, especially those who have dementia. When there's a chemical imbalance with electrolytes, especially in the body, drug interactions, sleep disorders are huge, especially when you don't get good REM sleep, brain injuries, fevers like from pneumonia, and such. So again, what we're trying to do is be able to recognize when you have a sudden change in confusion, to think always, okay, what could be the underlying cause of this? Is there a new medication on board? Might it be interacting with another medication? Like, that's the whole goal then, is to treat the underlying cause. So delirium symptoms, they can present with extreme confusion and agitation and an inability to follow directions. So because the primary cognitive domain that's affected by delirium is attention, that's where you will find this inability to follow directions. And there is an altered level of consciousness often seen with delirium. For instance, if you have two people who have dementia sitting in a day room in a facility, people will often chat back and forth to each other. Apart from when people, if they take a nap during the day, like say in the afternoon or just prior to bed, of course, people will be tired, but an altered level of consciousness is not part and parcel of dementia. So that's a really easy cue for thinking, okay, I think we're now dealing with delirium. And then the fluctuating states of awareness, and that is between combativeness, lethargy, and periods of being normal cognitive function, what that they previously had. We'll get into this a little more later when we look at the differences between the subtypes of delirium. With delirium also can come false beliefs like paranoia, suspiciousness, or visual or auditory hallucinations. We will now talk about delirium superimposed on dementia, so DSD for short, if you see this written as a diagnosis. So the term DSD was coined by Dr. Donna Fick at the College of Nursing at Penn State, and it's used throughout the literature now on delirium, especially, as an easy way of looking at delirium superimposed on dementia. So it happens when they both can occur concurrently with each other. So DSD is typically under-recognized by medical and nursing staff, but up to 89% of older adults living with dementia experience delirium when they're hospitalized. And when we think about why should we care about DSD, it is very common. When you look at 89%, it's burdensome, it's poorly recognized, and often overlooked. And dementia, when someone has dementia, they already have a pre-existing brain vulnerability, and that's why delirium is much more common with people who have that diagnosis. But just also clearly know, which I've never mentioned, delirium can happen at any age. A lot of younger people, especially in ICU, people who have brain injuries, people who have really high fevers, all of us can have delirium. But for right now, we're kind of focusing on delirium superimposed on dementia, and we're talking about the care of older adults at the moment. So when delirium is experienced, a person can appear paranoid and vigilant. I have often seen people look like this. I had worked with a clinical trial on using activities to help people shorten the length of time with delirium, and I worked in 8 nursing homes in central and eastern Pennsylvania. And this look on people with delirium was quite common. It is important today for us to also recognize and talk about delirium subtypes. So we have hyperactive delirium, and I will go through all 4 of these in a moment. We have hypoactive delirium, and then we have hyperactive delirium superimposed on dementia and hypoactive delirium superimposed on dementia. I'm going to go into little vignettes of these 4 conditions and in these follow-up slides. I do want to mention that these standardized vignettes that I'm going to mention, they are available free of charge from the Penn State College of Nursing. They were created again by Dr. Donna Fick, who has spent her whole life in this field. And they are really, really good for in-services at long-term care facilities to help with awareness and education on delirium and the subtypes. And there's questions to provoke more thinking and discussion about them. And if anybody is interested in getting them, I'm happy to send the information to Eric at the end of this presentation. So we'll go now into these examples of these subtypes. And I imagine that all of you have very clearly seen all of this in your during your nursing careers. So first, we're going to talk very briefly about dementia because it's very, very, dementia education, dementia awareness is very, very, very much on the top of its old news almost, and there's such a high awareness of it. But this is a case of Alan, and Alan is a 76-year-old male hospitalized for 1 day. I do want to say all these vignettes are taking place in acute care setting. He has not had any unusual behaviors, but his family reports that slowly over the course of the past year, he's been getting gradually more forgetful. He has more trouble dressing than he did last year. He seems to have more trouble finding the right words to say than he did a year ago. He gets confused more often than last year about where he's going. None of these changes happened all at once, but Al seems to be slowly getting more confused in his memory and thinking. His vital signs, physical exam, and EKG are normal, and all lab values were within normal limits. We don't know why he's in the hospital, but it's just an example of someone, how they present when they have dementia. Here, in the case of Donald, we're going to talk about hyperactive delirium. And I am quite sure that all of you have seen this over and over in your careers. So Donald is a 69-year-old male admitted to the hospital this morning. He has been doing fine with only mild forgetfulness. So again, he's got age-related changes, but doesn't have dementia. No obvious memory issues. Suddenly at midnight in the hospital, he walks down the hall towards the nurse's station looking for his father. And you know his father had passed away many years ago. When you remind him of this, he said he just saw his father walk past his room and insists on finding him. When directed to go back to bed, he becomes angry and accuses you of stealing from him and kidnapping his father and demands that you take him to see his father. Donald is up all night, out of bed pacing, searching through everything in his room. And over the next few days, Donald still has trouble sleeping. He seems much more distracted and forgetful than he did on admission. And when sitting up in a chair, he's pulling off his dressings and asking to leave the hospital. Donald says he sees people who have died years ago. He's reaching out in the air as if he sees something. When you try to reassure him, he tries to hit you. So this is very distressing for the person. This is extremely distressing for family members. And of course, in the hospital situation, then there's a whole safety issue here. So what is so important is that this is a new sudden change. So, and it's a hyperactive type of delirium. So again, the focus should be, let's look at why this delirium is there. We know it can be reversed, but then to treat the cause of it rather than sedating a person. This is the case of Betty. So she has hypoactive delirium, and so she does not have any dementia as well. This is just pure hypoactive delirium. She's an 80-year-old female hospitalized for 2 days. She was doing fine, no memory complaints. One morning, Betty does not want to get out of bed. She does not seem to be interested in food and seems very slowed down. She appears sleepier than usual and is disoriented to time, place, mistakes her nurse for one of her relatives. Does not seem to be paying much attention when you talk to her. Over the next few days, Betty spends a lot of time just lying in bed and staring into space. According to her family, she did not have a history of depression, sadness, or feeling blue. That's really important because sometimes delirium is mixed up with depression. And it's nice to clear out that she does not have a long-standing issue with depression. We'll get into the treatment of this a little later. Again, this is slowing down, very unusual change for Betty. The whole goal will be to see why this hypoactive delirium might be there, what caused it. Now we're pivoting to the case of Diane. So Diane has hyperactive delirium superimposed on dementia, so she has both. So she's an 83-year-old female hospitalized for 1 day. Her family states she's had increasing memory problems over the past year, problems getting lost while driving to a local restaurant where she has been many times, has more difficulty finding the right name for things. She also is experiencing difficulties, increased difficulties with completing her activities of daily living. In the morning in the hospital, you go in to check her vital signs and suddenly she is more confused. She tells you to stay away and tries to punch you. This is not her usual behavior at home. Again, this is happening in the morning, so it's not like like when you do have it, it can be all day long. It just does not have to be the sundowning times. She accuses you of trying to kill her and steal her belongings with paranoia present. She's disoriented to time and place and does not recognize you as a nurse. You leave the room and you hear her talking to herself and moving things around in her room. You return to check on her and you find that she has pulled out her IV. Again, she's amped up all of her energy. She's hyperactive. And the last vignette case is Carol. So she has hypoactive delirium superimposed on dementia. 74-year-old female hospitalized for 3 days. The family states she's had increasing memory problems over the past year, problems getting lost while driving to many familiar places where she has driven numerous times. She's also experienced increased difficulty in completing her ADLs. The family reports she does not have a history of depression, sadness, or feeling blue. Carol does not seem to notice when you talk to her and is much sleepier than before and falls asleep while you're trying to assess her. We did talk about in the previous slide that an altered level of consciousness is not part of dementia. So we can say with most certainty that this is the delirium that's causing this change. She's disoriented to time and place and does not recognize you at all. She will not eat or take her medicines. The next morning, Carol will not get out of bed. She's awake, although somnolent, and she's staring blankly at the wall. She'll not eat and show any interest in her food. When you attempt to assess her status, you notice that she is once again sleepier than usual, and she'll not remain awake when you are taking her vital signs. So now let's pivot over to the treatment of delirium. So the main ways of looking at delirium treatment is, number one, you identify and treat the underlying cause, and then you assist with calming the person to help restore the previous cognitive state. These people with delirium present, they need frequent reorientation of person, time, and place. Using eyeglasses, hearing aids, and dentures is so important so that they won't misperceive their environment. If they don't use their eyeglasses, they won't misperceive what someone is saying if they don't have their hearing aids. And then nutrition is so important. So the dentures, excuse me, if a person has dentures, that they are with the person. So another goal is to maintain proper noise and light levels, good nutrition and hydration, especially because if there's already delirium caused by, let's say, medication or anesthesia, and if the person gets hydrated, their delirium is dehydrated, their delirium is going to get much worse. And then providing appropriate cognitive stimulation and reassurance, and the use of medication with extreme caution. And delirium it's been proven delirium awareness lowers the use of antipsychotics in the acute care setting. I do not know if any of the facilities use the day clocks, the dementia clock. It is really, really helpful to people with dementia because the numbers are large. It'll say morning or evening to know. If it just says 9 a.m., they don't know what time of the day it is. So that's really helpful. And the reason why antipsychotic medications need to be limited just to the management of symptoms imposing a safety risk for the patient or staff, or highly stressful for the patient, like if they have hallucinations or aggression. But again, even using them with extreme caution, if a family member can't come and sit with the person, that having a family member present would be way, way better than medication. But if medication is used, it's a significant lower dose. For instance, it would be like 3 milligrams of Haldol versus the usual treatment of Haldol, say if schizophrenia was a diagnosis. There's risks and side effects of neuroleptics like higher mortality due to the increased rate of cardiovascular events, risks of extrapyramidal side effects, and then hugely a higher fall rate. And the medications used for the treatment of delirium, if needed, they should be time limited because there is no conclusive data supporting the use of medication for the treatment of delirium at this time. I have seen, I've seen treatment of, like, for instance, 3 milligrams of Haldol times 3 doses. So that's what I mean by the time limited manner. And that is often used with hypoactive delirium. When people are really slowed down, a family member will say, this is not how mom or dad were at home. And then it'll give that boost to get them back up to their previous state. But also what needs to happen is to figure out why they're having delirium. So awareness is key. 1.5 million emergency department visits annually in the United States because of delirium. And in the emergency department, only 35% of the staff are aware of delirium. Family members are often very unaware of delirium. It is a great service for facilities to have an in-service for family members also on what delirium is and the incidence of it, and especially for people who have dementia. And then with the awareness and prevention being, if they're hospitalized, to try, if at all possible, to have family members visit. So in long-term care facilities, the vignettes that were presented earlier were used, and only 37% of staff correctly identified hyperactive delirium. That is still way, way higher than what acute care is, because with long-term care facilities, staff are aware of the baseline of the residents in their care. It's going to be still slow for a few years, but it's getting a lot better, the awareness of delirium. So the reason why we should really think about this is there's prolonged hospital stays, and then of course the cost of that. There's functional decline, especially for the hypoactive delirium, because people don't want to get out of bed, they don't want to walk to the bathroom. There's an accelerated cognitive decline, and then post-discharge depression. there's a higher chance of mortality within 6 months of the index episode. So the first episode of delirium, has been proven that people will have a greater risk of dying within 6 months if the delirium is not recognized and treated. And then there's a health economist out of Hershey Medical Center, and he looked at the cost of delirium care. He does a lot of work with delirium care. And while this is a little older statistic, it's still very important to know that in 2008, the national burden attributed to delirium care was 152 billion, with longer lengths of stay, falls. And that year, the cost of the care of delirium was more than the cost of the care of diabetes. So this is a huge problem. So for awareness tools, there's a need for family to be aware that a sudden cognitive change in a person with dementia is likely delirium. We've touched on that before. One of a really helpful tool to know if you have delirium is the confusion assessment method. It's known as the CAM. This instrument is available free of charge online. There is training free of charge online for it. It is good to look, there are, in this screening, there are two features that need to be, there's 4 features. The first 2 need to be present to diagnose delirium, and then one of the last 2. It is good to do, it would be good to do this a few times a day, but at least once a day, because then you will be able to see if the confusion is getting less. One of the recent changes, and it's been used widely now, is the CAM app from the Apple Store. So it's called Delirium Ultra Brief CAM Delirium Tool. The really nice thing about this tool is that it'll tell you right away if delirium is present. There isn't, like with the paper CAM, or if you can also download it and have it online, you have to score that yourself, but the CAM app will score for you. The other important thing, when you think about the number of people that go to the emergency department with just delirium alone, they absolutely need to have a baseline mental status communicated to them to help with their treatment and diagnosis of delirium. Prevention is better than cure. So we're going to talk about delirium prevention for a little while here. So accurate medical information is always needed to prevent complications like over-medication, falls, extended hospital stays, all that can exacerbate the symptoms of delirium. And allergies, I would pop allergies in there also. Delirium early detection is so important. Encouraging family members to visit, especially in acute care, to provide personal items and photos in the immediate environment to help soothe a person. Know significant family and friends, favorite activities, place of birth, occupation, all things that can help soothe a person. I presume I'm preaching to the choir with the Breer's criteria for medications not to use with older adults. It's updated annually. There's a person from locally here in Pennsylvania that sits on that national board. It's free of charge online. It is reviewed, yes, it is updated annually, I've said that. And the medications that put people, and especially older adults, at risk for delirium are antipsychotics, narcotics, some antihistamines like Benadryl and Unisom, anticholinergics, Dynatap, Tylenol PM, Advil PM, and sedatives like diazepam and lorazepam. And it is now known and proven that at least 30 to 40% of cases of delirium can be preventable. And prevention is the most effective strategy for reducing delirium frequency and complications. So we'll talk a little more here about prevention strategies. So identifying at-risk patients. So of course, they are people who have dementia as an underlying condition. To reduce environmental disturbances as much as possible, if work has to be done in an area where older adults are, if people can have an activity, if it can be done as quick as possible, it's not always possible, but just to keep in reducing environmental disturbances, keep them at a minimum if at all possible. Increase reorientation interventions, maximize early mobility, provide adequate hydration, enhance sleep, or use non-pharmacotherapy measures to promote sleep. So using white noise, some kind of sound apps that suits a person, music, whatever what is good care for that person. Providing therapeutic activities, optimizing hearing and vision, which we mentioned before, providing emotional support, especially when it is a scary thing to have delirium. And there are really good YouTube videos of younger people who experience delirium when they were, especially ICUs are really hard for delirium, or like there's a real high incidence of delirium because often there are no windows in ICUs. Now they do have those screens that simulate day and night, which is really important. But it is really insightful when you hear people talking about what it was like to experience and how frightening it was to experience delirium. Avoid moving a person unnecessarily, like changing rooms, if at all possible. Check for changes that might indicate delirium. Place the patient's bed as near as possible to a window so they notice changes in light, and then arrange for education classes on delirium. There is a program out of Yale, so it's called HELP, Hospital Elder Life Program. So it's the program was started by Sharon Inouye, and she's the one who created the CAM, the Confusion Assessment Method form. And they give a booklet to all the family members. So this is available free online too. So it talks about sleep hygiene, the need for 7 to 9 hours of sleep at night to consolidate memories and clear beta amyloid. It's a really helpful booklet for very simple things that can be done that make a huge difference in the quality of care for an older adult. Person-directed care is now very much on the minds of people in long-term care. I'm just briefly going to talk about this because I'm sure it's something that has that's high on the list of what's communicated in your facilities. So person-directed care versus person-centered care. Most long-term care facilities have always had person-centered care to try and treat the person as much as possible. But when the resident actually directs their own care, the person-directed care, it is really, really shows a very big increase in the type of care, the type of quality of their lives. So there's one community effort with person-directed care resulted in substantially reduced falls, including 2 fall-free months, the complete elimination of antipsychotic medications, and increased resident engagement in activities. So there's a free certificate course online through the Greenhouse Project Center for Innovation about person-directed care. I'm now going to talk briefly. This is, I was the project director for this reserve study for delirium superimposed on dementia at the College of Nursing at Penn State for 5 years. And we were looking at testing the efficacy of activities, the stimulation, using recreational activities to stimulate older adults to help resolve delirium superimposed on dementia. And the reason reserve is there, so cognitive reserve is a term bandied around quite a bit with in research with delirium. So all that reserve, cognitive reserve, it refers to the ability of the brain to cope with damage while still functioning adequately. So there are many things we can do in our lives. So if we have an episode of delirium, if we have like really high sustained fevers, that we're able to kind of get through it okay without any damage. And cognitively stimulating recreational activities, they promote the processing in the cognitive domains that are affected by delirium. And what they do is they increase cognitive reserve, they reduce delirium severity and the duration of delirium. So the cognitive intervention we did, we used activities targeting the cognitive domain of attention. So it's the 5 domains affected by delirium are attention, orientation, memory, abstract thinking, and executive functioning. So we would have an activity prescription written on their current level of delirium. So on the CAM, if they had 4 positive symptoms, for instance, and they also had dementia, we would make the activities for each of those cognitive domains pretty simple. And then as the delirium resolved, we would amp up the level of the activity to help them processing. So the activities were targeted to interests and hobbies. We use the Farrington Index with the families to know what their hobbies, what they worked at. Pets, family members, we would target everything. Like if somebody was a baker, we would talk a lot about, tell me, for executive function, for instance, we'd say, tell me how you would get everything together to bake the birthday cake that your family members like, something like that. These activities, often when someone had a lot of delirium, I would go in with these activity prescription. I might only have someone's attention for 2 minutes the first day, for instance. And sometimes it was less than 2 minutes. But then it would, as they got better, you would increase it. But there is absolutely no more help gained by doing it any more than 15 minutes a day. If you target those 5 cognitive domains with this activities that are targeted to the interests of the person, it has such a long-lasting effect. I was at a local facility, long-term care facility here, and I went down to physical therapy to bring a person back to their room because they got delayed. And the physical therapist said to me, I don't know what you guys are doing, but like this person is way more engaged now in their care as they went through this program. And also then when I took that gentleman back to his room, he had a picture of his family on his nightstand, and the hallways were very distracting for him because there's the buzz going on, all sorts of activities in the morning. And when he got to his room, he said, that's my family. So he was really relieved when he had a picture of his family member there in his nightstand. These things all make such a difference to older adults. There's positive outcomes, decreased lengths of stay already proven with this. The one activity that we found most people liked was finishing the phrase. That was the most popular activity. We would have like nautical or aviation themed activities, battle statistics for a history buff. We trained nursing assistants, recreational therapy assistants, activity assistants to do these activities. This no more than 15 minutes a day, and family members can be trained to do this too once the prescription is written and targeted personally. So the types of things we would do at a bedside, we do word or object searches when we would never do this, for instance, when a person would have 4 symptoms of delirium as the delirium resolved. That would be a really good one. Dot to dot is most people found pretty easy. Crossword puzzles, again, a little later, very simple crossword puzzles. Naming the tune was huge. We would record music they would like. And, we all know that music is very, very soothing to older adults. We would have them identify some sounds with, again, we would record sounds depending on what they worked at or what they liked for hobbies. But we would also put things like, again, going back to someone who baked, we would have a string bag. We would have them put their hand in and identify, for instance, we might have a wooden spoon in there. We might have like an egg beater. We might have a measuring cup, things like that. We kept changing it up. The Price is Right is a good activity, and really simple bingo. So right now I'm going to pivot to a companion case that we have created to help older adults, and especially with delirium in mind, but this is also created for people who have dementia, but also for solo agers. So it is a case designed to help resolve delirium using a simple calming approach. And the contents include medical information, memory triggers, and personal items. And it keeps essential information easily accessible and ready when you need it. There is a grommet on the side for cell phones and for hearing aids to be charged to let the cords come in there. So with older adults, it's really important to know that pets and hobbies represent consolidated memories, which are very, very positive. And when you have someone with delirium, it adds absolutely no stress to the person when talking about consolidated memories. And again, we mentioned earlier, having 7 to 9 hours of sleep, one of the things that does for all of us is to help with clearing beta amyloid, and then it consolidates memories also. And then when a person looks at their situation more positively, what the power of positive thinking. So it broadens the scope of attention and increases brain resources. So when you have somebody who's not depressed, not hypoactive delirium, they're able to recall things a lot easier. So it's really important then that we offer a lot of reassurance to people who have delirium. So the case items, there is a video that we had difficulty loading just with our technical issues at the beginning. But when you go on the Medical Mirror website, there's a really brief video that shows what the Medical Mirror case looks like. So feel free to go on there and have a look at that. And I apologize that we can't load it here at the moment.
Yeah, Paula, there's no volume. You should probably just go to the next slide.
Okay. All right. Sorry about that. So you can see that online. So the exterior of the case, so it has a sticker to identify the owner. If a person has a maiden name, that's on top of the case. There's a photo sleeve for personal photo, and there's magnets that signify the important belongings like eyeglasses, dentures, hearing aids, cell phone. And then there's that magnetized whiteboard for personal messages, which can be really reassuring if you're going to say, I will be back in to visit you at 5 p.m. And if the person has, for instance, a clock and they know when to expect another family visit. There's magnets for the falling star symbols where the fall risk is able to be used, and that they can be used at the discretion of the facility. And on the back, there's 2 additional 4x6 photo sleeves to feature family, pets, activities, places, etc. And again, this all offers comfort and familiarity when someone is in a different care setting. So on the inside of the case, there are 2 albums, and the album on the left, there's a HIPAA form, a card with all the information, medical insurance information. That card then needs to be taken out if an older adult brings this case to the emergency department, whatever family member wants, that information is passed along to the emergency medical service or to the admitting office, then that can be brought home, that red card. Also in there, there's information on contacts and who's local, who's to be contacted first, the medical history, allergies, food preferences, sleep preferences, medications, advanced directives, a copy, there's a copy, an area for cultural preferences. There's a question that is asked, have you ever been diagnosed with cognitive impairment or dementia? That's extremely important for the hospital to know that. There's a place for having a copy of an EKG and the baseline vital signs. EMTs asked us to do this because they don't know when they have an EKG if there's an evolving MI, for instance. If you have a baseline EKG, they know this is the new issue. There's a place for what agitates and soothes a person, living will, pulse document. All of that is the album on the left. And then the album on the right is a life story, photos with names of people and pets on the back. So that has to be all filled out by the family. And then on the inside, there's a box for the falling stars. There's you can personalize this. There's magnets provided for if someone has dentures, for instance, eyeglass case, whatever is needed. But the voice recorder is really popular. So it includes, you can include a personal message or a favorite song, and it is a proxy for a family member being present. And then that can be, there's magnetic receptive material on the inside and on the outside. So that voice recorder can be removed and put on the outside at night if a person wants to keep playing it. It is very difficult to erase it, even if someone has extreme, like hyperactive delirium, because you have to use a paper clip to press down to be able to record. So it's a non-issue. And then all of this information is valuable information for care staff to know about the life of the person. So if somebody is coming down with the UTI, they're very agitated, up at the nurse's station, like one of the vignette featured people, you can take this album out and go through it and talk to the person, and that will really, really provide a lot of reassurance. So this is Actuated Medical. We're located in Bellefonte, PA, 22 team members here. And it's a woman-owned company. I'll let Maureen talk more about that if there's any questions later. Before we pivot to questions, I just want to briefly go back on what the take-home message, hopefully from today is the importance of recognizing delirium versus dementia. We have a long way to go with awareness. We've made a lot of progress, but information on delirium and dementia was always presented together for instance, with the American Gerontological Society for, I think, like 82 or 3 years, because I know a few years ago, there was a celebration of the 80 years. I think it was started in 1942, I think. But the American Delirium Society was only inaugurated in 2011. I was really fortunate to be able to attend that inaugural meeting in Indianapolis. And it was just a whole new world opened up to everybody when they were pulling apart these delirium and dementia diagnoses. So in your facilities, if you have a new admission or a resident returning from the hospital on antipsychotic neuroleptic medication, please think delirium, even if a diagnosis is not present. If you see a diagnosis of brain disorder, like encephalopathy, things that we talked about earlier, then ask about stopping those neuroleptics, because again, they have increased mortality for older adults who are using them, a lot of increased cardiovascular events, the side effects falls. And we will serve older adults way, way better with greater awareness of delirium information being brought to everyone's attention. So that is it from me. Here's the team at Actuated Medical, and I'm happy to try and answer any questions people have.
I first want to thank Paul and Maureen for taking the time to present today. Our chat window is open. If you do have any questions, please feel free to submit them there and we will answer them as best as possible. If you want to follow up after this webinar, we're happy to pass those questions along to Paul and Maureen as well.
And I'd just like to say thank you, everyone, for your time. Appreciate it. And if you are interested in looking at the My Medical Mirror, there is a website called mymedicalmirror.com.
Paul and Maureen, I'll just give another minute in case somebody's typing, but right now we have no questions at the moment. Okay.
Okay.
If you do have questions, please feel free to pass them along to Kim or myself, and we're happy to pass them on to Maureen and Paula. We want to thank everybody for attending today. Thank you for your patience as we work through our technology issues. Paula and Maureen, thank you very much for this presentation. It was very enlightening. As somebody who's now dealing with an elderly loved one who is going through care right now and dealing with some minor memory care and dementia issues, this is very helpful for me just to listen to. So thank you for the knowledge that you presented today. Thank you both for your time. And we will follow up with all attendees on information about your credits and the access to this webinar recording following this conclusion of this event. So thank you all for your time today. Have a good one, and we'll see you soon.
Thank
Thank
you.
you for the opportunity.
Thanks. Bye.
Bye.